Do I have 2 minutes or 4 minutes?
You have 4
Okay.
for both bills.
Okay, thank you. Dr. Robert Fine, I'm the Director of Clinical Ethics and Palliative Medicine for Baylor Scott & White Health, which, as most of you know, is a rather large healthcare system. We cover a population that's a geographic area that holds about 1/3 of the population of Texas. I'm speaking on behalf of Baylor Scott & White Health, the Texas Medical Association, the Texas Hospital Association. I prepared remarks, and I'm just going to put them aside, and I want to say ditto to everything that Dr. Casanova and Dr. Morrow, my medical colleagues, said. What's been interesting to me listening to this today, and I've been involved with this since the original law was written, 98 and 99. I was part of the negotiations that created the law. It was a good law. Texas Right to Life endorsed it. Organized Medicine endorsed it. It wasn't a perfect law, and we always knew that. We always knew that. It clearly can be improved. I am for 1944. That, I think, brings real improvements, and I am against 917, which really totally guts the whole concept of achieving balance between these competing interests that you all have wrestled with. Yes, patients have an interest in a right to life. And yes, physicians have an interest to honor their ethical oaths and codes, which go back 2,500 years, not to prolong dying when you cannot make the patient better. That's absolutely critical. So when you get to 917, it just says it doesn't matter what the ethics committee says because you have to keep doing the wrong thing, doctor, the thing that you believe is wrong. I believe there are 2 great dangers to this. One of those dangers is just the moral distress it causes to a physician. I think Dr. Casanova referenced a physician saying, but what about when I go home at night and pray to my God? What does that mean? Well, moral distress occurs when a professional is forced to violate their professional oath and code and do something they think is wrong. That leads to burnout. Both increase the risk of medical errors. There's some debate if it increases the risk of suicide. It certainly causes people to leave the profession. ICU nurses don't get talked about enough. They are often the ones with the greatest moral distress. Dr. Fine, why are we being forced to do this to this patient? They're the ones seeing the suffering. You don't have to call it torture, but it's suffering. And part of my specialty is palliative medicine. We treat suffering. We're the ones that go in and try to make that better. The other danger that I'm really concerned about is for patients. These cases primarily happen at the tip of the pyramid hospitals. These are ICU cases. These are the sickest of the sick. In Baylor Scott & White, we never have a case like this in Marble Falls or in Brenham or in College Station because those patients get transferred to Temple, to the original Scott & White, or to Baylor University Medical Center. If we get to the point, as the case Dr. Casanova described, where we've got the patient on ECMO, there's no place to transfer that patient to. There's no other place to go. If doctors come to perceive that if they agree to accept a patient and initiate what we would call a therapeutic trial, we want to save lives. Let's try to save this patient. If they come to perceive, if I start it, I can never stop it, my great fear for patients is they will stop accepting those. I'm going to close with a plea. Chairman Colhurst, you referred to Groundhog Day, and this is Groundhog Day for me as well. All right? 99 was good, everybody was on the same page, it was kumbaya. 2003 was okay, and then ever since then, it's been this constant battle. The solution to this is not to keep bringing up the same ideas in the legislative session over and over. I believe the solution to this is to appoint an interim study committee of all stakeholders who wish to attend. I'd be happy to talk offline about that. Let that study committee bring back recommendations to the legislature and get away from this competing bills and competing narratives. Because I'm sure that our compatriots in Texas Right to Life will say, well, we don't recognize anything Dr. Fine is saying. I promise you, the cases they describe, I'm kind of going, I don't know where those are happening. They couldn't happen at Baylor Scott & White Health. You can't use this process against a competent patient who's writing letters to people. We don't think that's even legal. So if somebody is doing that, I think they're violating the law. Thank you very much, and I'm happy to take any questions.
Thank you, Dr. Fine. Senator Hughes.
Thank you, Madam Chair. Dr. Fine, thanks for being here. Have you watched previous hearings on this subject in the Senate, in the House?
I've participated in most of them, yes.
Have you heard families testify about their experience with the law?
Yes.
Do you not believe them? They were giving sworn testimony just like you are today.
Yeah. I think what happens, and I feel like one of the senators referred to this briefly earlier today, when we are grieving, we go through well-recognized stages of grief, and they don't all fall in order, but it's a combination of denial, anger, bargaining, and depression. And grief is real. I try to help people through grief every day of my life, at least when I'm seeing patients. And it changes our perception. And what we often find, Dr. Casanova, I think, alluded to this, when we do ethics consults, most of ethics consults, we help resolve that grief. We help improve the communication. So their perception when we are grieving, when I was losing my father and my mother, my heroes, I was grieving. I was not the same man. You can ask my wife. You can ask my colleagues. We are not the same when we're grieving. So it's not, I don't want to get into who's telling the truth. It is complicated, and this kind of forum is not the best way to resolve that complication. And if I may respectfully say, sir, I think that the problem that we struggled with back in 98, 99 was we did not want to give all the authority to either side of this tough moral debate. We didn't want to say, oh, doctors are always right. But we also didn't want to say surrogates are always right. We never have had a case like this where we're talking to the patient. And another thing we found about families is they're often secretly divided. And we have had, in big families, there's typically, the larger the family, the more likely there's a dominant family member. That dominant family member may either be demanding withdrawal of treatment, or they may be insisting on maintaining treatment. Other family members will not challenge them. Then they'll call me privately and they'll say, Dr. Fine, I just want you to know I disagree with my sister. Well, I appreciate it if you'd say that in the meeting, please. Oh, no, I can't do that. I can't challenge my sister. So that's another reality, is that we see divisions within families, and that bubbles up to the surface in ethics consultation. This process is actually used, as Dr. Casanova said, and he took over leadership of ethics at Baylor University Medical Center when I took over leadership at Baylor Scott and White. He's had 5 of these cases in 17 years. This is, at least in our world, again, to hear Texas Right to Life, they're happening every day. I think there's a disconnect, and I would love for us all to get together.
Doctor, I haven't heard anybody say they're happening every day, but as you know, the truth is important, not just your perception of the truth.
Right.
So let's talk again about the families who've testified under oath. Now, and you and I have discussed this before, I don't remember a whole lot of cases coming out of the institution where you serve, and I don't question that. But have you heard witnesses testify in front of this committee, in front of the House, about other institutions? We're not denigrating those institutions, but have you heard that testimony?
I have.
And those families presumably were there when those events took place, since they swore that they were. I wasn't there. You weren't there.
Yes.
Do you believe what they said?
I believe that they perceived what they said. I don't believe that was the full reality.
And Doctor, that statement may get to the essence of our disagreement on this bill. Thank you for your testimony.
Okay.
Thank you, Madam Chair.
Yep. Thank you. Any other questions?
Thank you very much for your attention and for the work you do. It's not easy what you all are being asked to do. I would really encourage an interim study group. Thank you.
And Dr. Fine, I do want to say this, obviously Baylor Scott and White's, something, I'm proud to have y'all in my district, in my hometown, such an important institution. A little bit what Senator Hughes said, maybe y'all are the gold standard on these issues, and we have some bad actors out there potentially. So thank you for your thoughts. And
thank you, and I appreciate that. And if there are bad actors, you know what, let's just say there are bad actors out there. I don't think Senator Hughes' bill, in all due respect, Senator Hughes, and you and I have spoken personally about this in the past, I don't think that's the way to fix the bad actor problem. I think this is really complicated. And by the way, I think there a whole lot of other things that could be fixed and made better in the Advanced Directives Act. Remember, it was passed 20 years ago, and it was following on 3 different laws written over 20 years earlier. It's good to revisit these things from time to time. Medical science has changed. So it's just a plea, because I too am tired of Groundhog Day.
Yep.
Thank you.
It is time to revisit it. It's, where do you land it is the issue. And truly, can the groups come together? I think that's the issue at hand, where it's not a circling firing squad, and yet we all have the same goal, is to treat life as precious as it truly is, given to us from our Creator. And in those final days that may not be your final days, how do we play God? So,
and nobody's playing God, and physicians couldn't agree more about saving life. Cure, comfort, absolutely imperative, but do no harm. And that's one of my big concerns, as I said, to patients. I believe they will be harmed by 917. I believe the net result will be that doctors, and it'll be subtle, it'll be subconscious, it'll be this, boy, if I start that, I can never stop it. The notion of a therapeutic trial is really important in medicine. Let's try this and see if it works. But if they try something and see if it works and then find out when it doesn't that they cannot stop it, I'm pretty certain that they will say, I'm not going to do that again. I'm not going to try that again. That's my concern. And I say that from the perspective as somebody in this big healthcare system where we have 2 extraordinary state-of-the-art hospitals, tip of the pyramid, and then probably another 5 or 6 that are right below the tip, and then a whole bunch of wonderful good hospitals below that. So I see how transfers work. Anyway, thank you so much.
Look forward to future conversations. Thank you. The chair calls Rebecca